I'm excited to be here today with Brad Smith. Many of you know Brad, but I'm going to give him an opportunity to introduce himself.
So I'm Brad Smith. I'm a healthcare entrepreneur. Back in 2013, started a company called Aspire Health, which was a home-based palliative care company. We built that for 4 or 5 years, and then in 2018, sold it to Anthem. I went into Anthem, became the chief operating officer of their diversified business group, and then out of the blue in early 2020, got called to go up to Washington, D.C. So went up there to run something called CMMI, which is the Center for Medicare and Medicaid Innovation. Actually ended up getting pulled mostly into the COVID response, actually, while I was there. So spent probably 9 of my 12 months working out of the West Wing on the COVID response. But after the administration, went back to Nashville, where I'm from, and we started up a little group called Russell Street Ventures that's focused on launching a small number of companies in the value-based care space. The first one we launched was called CareBridge Health, which is focused on the managed Medicaid population, especially folks with physical and intellectual disabilities. And then the second one that we just launched is called Main Street Health, which is focused on rural seniors.
You've been very busy the last 6 years since we first backed you. Building one successful company is hard enough, but now you've built 3. Can you talk about the lessons you learned at Aspire and how you're applying those to the other 2 companies?
Yeah, it's interesting. We're definitely still learning them, I think, as we go. But, I think at Aspire, everything felt hard, and there were roller coasters all the time, up and down. And I think what's interesting about doing it a second and third time is you have a little bit more insight into that is how it's going to feel, and you can kind of plan for it a little bit more. And I think that looks a couple of different ways. One way is I tell the team that's how it's going to feel, and I think that makes when it goes up or down on a given day, people are more prepared for it and they're more used to it. And I think that helps people get through it a little bit easier. The other thing is, we've really, I don't want to say over-resourced, but we know what's coming. And so we've hired a little bit ahead. It still feels like, honestly, we're hiring behind, but I'd say relative to Aspire, we're hiring ahead a little bit. I think we've learned some things on the business model front too. At Aspire, we didn't take full risk for our population. We had a per member per month fee. Moving to a full risk model, one, in today's environment has different implications for valuation. But I think 2, creates opportunity to have larger margins too, transparently, because you have the total cost and you can also do a lot more things clinically to improve quality.
After the sale of Aspire, as you mentioned, you went to CMMI, the innovation arm of CMS. And I think you had great plans for working on new payment models. But then the pandemic intervened, and I think you did both, and you actually did accomplish some things that were very interesting in terms of new payment models. But talk about the pandemic response, your involvement in it, and then other things you accomplished.
Yeah, for sure. So, I went up to DC in January of 2020. And for the first month or two, I really was one of the few people at HHS who was involved in the pandemic response. And there was a night in early March when the president gave a big speech about COVID. And right after that, Jared Kushner ended up getting involved in the pandemic response. And so he called Adam Bowler, who many folks might know, who then called me. And I ended up going over to the West Wing on the night of March 12th. And I don't think I left the rest of the year. So, now, looking back, it feels like, I don't want to say that it's steady, but we have vaccines. People kind of know what to expect. But in those early days, really nobody knew. And if you remember early March, the cases were just going up so fast and everybody was afraid New York was going to get overrun and there were not going to be enough ventilators for people. And so really in those first couple of months, we ended up leading out of the White House a lot of the efforts to do things like fly PPE in from Asia, because it turned out the supply chains in the US were too tight. We ended up standing up the first community-based testing sites, which now seems silly, but then seemed like an extraordinarily hard thing to do. We also launched Operation Warp Speed, which obviously developed the vaccines. And so it was really a really interesting time to be in government, where you happen to be in a role where your background can help with the major problem that's occurring at the time, and learned a lot from it and feel really fortunate to have been able to serve. As kind of that peak ended in the spring, I did free up a little bit to go back and also do my CMMI job that I had gone up there for, which was also really interesting. When I went up there in January for the first month or two, one of the things that Seema, who was running CMS, and Alex, who was running HHS, asked me to do is kind of, CMMI had been around for 10 years. And they said, hey, can you kind of go back through how everything's gone the last 10 years? We spent about $10-15 billion at that point, and see kind of how it's working in aggregate. So we went back through all 54 models that CMMI had launched in the past 10 years. And what was really interesting, because nobody surprisingly had actually put all the results together, is only 5 of them had saved money. And the ones that had saved money tended to have to do with pricing or utilization management or kind of things that you'd probably think of as more traditional kind of ways of doing things. And so when you kind of looked at that, you said, hey, does this mean that value-based care isn't going to work? And I think my answer to that was, no, it doesn't mean that. It just means that it's really hard. And I think as we dug in on why were the models not saving money or having the quality improvements we were hoping, it turned out the details of these things really mattered, and things like how you set a benchmark. So if you set a benchmark based on an average and you allow people to pick if they want to participate, the people who are below the average participate and the people above the average don't. So some of the things when you looked at them were pretty obvious in retrospect, but I think there were a lot of learnings about how you have to set up these models to really, 1, generate value for patients, but 2, generate value for the system overall. And I'm hoping now that I'm back in the private sector, we can take some of those lessons.
Yeah, great. I hope so. I think you've already started 2 other companies, CareBridge and Main Street. And are thinking and have this incubation engine in Nashville. If you could talk about that and talk about, again, sort of lessons learned and how you're applying them, and what is CareBridge doing, and then how you working on Main Street.
Yeah, for sure. So moved back to Nashville right after I left DC and started up Russell Street Ventures. But really, it was just a platform to be able to start a couple of companies. And I think one of the things I'm learning is I just remember how hard it is to start companies. So we'll see how many we end up doing. But we're really excited about the 2 that we've launched. So CareBridge is a company that focuses on folks who are receiving home and community-based services. So physically disabled, intellectually and developmentally disabled. And I'd always wanted to go after some of the hardest populations, and I thought there was a really interesting opportunity to really care for them in a different way. And we bumped up against them a little bit at Aspire. Many of these folks have a caregiver. Most of them, all of them, have a caregiver coming to the home. And at Aspire, we never really figured out how to leverage that person as part of our team. So at CareBridge, we've really built a model that leverages that caregiver, really as kind of the front line of the interdisciplinary team. So we send these little tablets to the patient's homes. The caregivers, by law in most states, actually have to check in and check out is what it's called, but kind of say when they get to the house and say when they leave. And what we do is we ask them a number of other questions. So if we know that, Miss Smith has COPD, we'll say, is Miss Smith having a hard time breathing today? And then they're able through the tablet to connect to our nurse practitioners and our social workers and our pharmacists. And what we found is that, 1, caregivers and families really love it. And then 2, we find that it helps keep people at home where they want to be and out of the hospital. And so we're seeing, good early signs of cost reduction. And, the company's growing really fast. We launched it just a couple of years ago, and it's already in 10 states. The second one that we're doing is called Main Street Health. It's focused on really rural value-based healthcare. I've always been really interested in rural. My wife is from a little town in Alabama called Abbeville. Her dad's a peanut farmer. My mom's family is from rural East Tennessee. And as you know, my first job out of college was driving Bob Corker around to all 95 counties in Tennessee 2 or 3 times. So we're really excited about that one too.
Yeah, no, that's great. So let's talk more about Main Street, because there have been a number of these value-based primary care companies created. VillageMD just announced their deal with Walgreens this week. You're applying it to rural. Nobody else has done that. I think it's really hard to do. Maybe you can talk about the model and how that's different from the other value-based primary care companies that are out there.
Yeah, for sure. So in terms of the business model I would say is very similar to the other folks who are out there. So really the question for us was how to figure out the delivery model in a way that made sense in rural settings. And so we spent a lot of time driving through small towns and just trying to understand kind of what are the assets that are already there, because we believe that you couldn't kind of create something new. You had to leverage what was already there. And what was really interesting is, 1, you had primary care physicians. They were definitely declining, and many of them were aging, but they were still the largest practices in town. A small town of 3,000 or 4,000 people might have 2 or 3 practices, something like that. One of the things that I hadn't really experienced as much was independent pharmacies. In many of these small towns, half the scripts could be picked up at an independent pharmacy. And the other thing that was interesting is that, wherever there were kind of a 4-lane intersection or two four-ways kind of crossed, you'd have the McDonald's, you'd have the Wendy's, and in between you would have an urgent care. And so we really believe that figuring out a way to partner with those community-based providers could be really interesting. And so, the model that we've built has two components to it. So one, we embed what we call health navigators, or like community health workers, into each of the practices in the pharmacies, because what we really believed was that, rural is so relational, and we really felt like we had to be on site, meeting with people, embedded in the community. And so having those health navigators who are seeing patients as they come into their pharmacy or as they come into their PCP is, we think really important. At the same time, we knew that, it was going to be hard to find new specialists and new physicians who were kind of in these local communities. And so we have a big virtual component that connects with the health navigators who are in the clinics, that connects with the PCPs and the pharmacists. And we found that patients are really open to that too, especially when it's facilitated by the health navigators sitting in their pharmacy or sitting in their clinic.
It's great. Well, we love it because it's such an underserved market. So we're excited to be part of that. So if you were going to create a fourth company, what would that be in? Do you know yet?
I think about it a lot. I mean, I think one of the, we've spent a little bit of this year thinking about that. Yeah. And I think if there was another area we're going to go after, it'd probably be serious mental illness. It feels like a very underserved population. And even though there's a lot of behavioral health companies, a lot of them are focused on the commercial population or folks with kind of mild to moderate depression. But we really feel like at kind of the farther end of that, there's an opportunity similar to like an Aspire or similar to a Landmark to kind of take full risk on these folks with schizophrenia and bipolar and severe depression. And what we found, at least in a couple of states that we've looked at, is there's a few places they tend to aggregate in terms of places they go for their care. And we think there could be a really interesting model and partner with those folks who aggregate them and figure out a way to deliver care more longitudinally and in a more comprehensive way. So we'll see if we can get 3 off the ground or if two's enough. But if we're going to do one more, that's probably what we go after.
Okay. 3's pretty good.
Yeah,
3's pretty good.
Yeah.
Great. Well, thanks for being here with us today and taking a break from the health conference. You can see Boston behind us.
Well, thanks for being a great partner. You've been just incredible. So thank you.